Good afternoon, everyone. It gives me great pleasure to welcome you all to this fifth edition of uh, Medanta Echo and Cardiology webinar series, which has been happening every month. During the last four webinars, we have discussed topics which are hugely relevant to every clinician or physician who's treating patients with cardiovascular risk factors or cardiovascular disease. And today's topic is another such topic, that is heart failure. We all know heart failure is a huge public health problem, and there's so much happening both in terms of diagnosis of heart failure and management of heart failure in the recent few years. And to discuss this, we have a very eminent panel of faculty members here. The session will be chaired by Dr. S.N. Narsingan, and the speakers will be Dr. Kasliwal, who is the chairman of Clinical and Preventive Cardiology at Medanta, and is the driving force behind this webinar series and Medanta Echo and Cardiology meetings that we've been having every year. And the other speaker is going to be Dr. Burkule, current Vice Chairman of Lipid Association of India, current President of Indian Society of Hypertension. He has been an adjunct professor at the Tamil Nadu Dr. MGR Medical University. He is also Dean Professor M. Vishwanathan Diabetes Research Center. He is Managing Director of SNN Diagnostic Center and SNN Specialties Clinic, Chennai. Dr. Narsingan has been a prolific researcher and academician. He's published numerous research papers and book chapters, delivered numerous guest lectures. His most significant contribution in the recent times in terms of publications have been the Lipid Association of India Guidelines on Lipid Management, Part 1, 2, 3. Dr. Narsingan has also been awarded several important awards for his contribution in the field of medicine, including the Lifetime Achievement Award by the Tamil Nadu Dr. MGR Medical University, several Master Teacher Awards from different societies, and he's also been awarded by World Hypertension League for setting highest clinical and academic standards in the field of medicine. So I hand over the proceedings to Dr. Narsingan, sir. I request him to introduce the topic, speakers, and then start the webinar. Thank you, sir.
Yes, sir. Good evening, everyone. Most respected Dr. Kasliwal, Dr. Manish Pansal, and Dr. Burkley. It is my pleasure to be part of this scientific session on heart failure. Every year, Medanta had been conducting this program, and this year, probably this is on virtual platform. The theme of this particular conference is on evaluation and management of heart failure and ever-changing paradigm. At the outset, I would like to thank Dr. Kasliwal for giving me this opportunity. And I must also thank Dr. Manish Bansal for the praising word that he showered on me. Today, we are going to have two eminent speakers with us to talk about the heart failure. The first speaker is going to talk on how should we diagnose heart failure in 2021, a clinician's primer by Dr. Nitin Brookley. And Dr. Nitin Brookley is actually a senior consultant cardiologist of the head of the Department of Echocardiography at Jupiter Hospital, Mumbai. And after the first talk gets over, we will be probably getting another talk by none other than Dr. Ravi Kasliwal. He is the chairman of Clinical and Preventive Cardiology and is an adjunct professor of cardiology, Medanta and Medanta City. And I'm really happy that we are going to have a good insight into the subject on heart failure. All of us know that heart failure, the incidence, the prevalence is increasing in alarming proportions. At the same time, we are also witnessing huge mortality following heart failure. In spite of the fact that we had seen so much of advances in the last 1.5 decades or so, with respect to diagnosis, with respect to the management of heart failure. And it's Dr. Casliwal, I would like to introduce Dr. Casliwal. He is a chairman, Division of Clinical and Preventive Cardiology, Community Program, Medanta, Medicity. Dr. Casliwal has a distinguished cardiology career spanning more than 4 decades after the receiving the medical education and training from the finest institutions. Dr. Casliwal is a BC Roy National Awardee, and he has, to his credit, 350 scientific research papers, and he is the founder, editor of the chief of the Journal of Clinical and Preventive Cardiology and Applied Echocardiography in coronary artery disease. I think I had been associated with Dr. Gavi Kasliwal almost for every year this particular meeting, which is coming out from Medanta. Sir, we welcome you, sir, for this scientific session. Let me also introduce the other eminent speaker, the cardiologist, Dr. Nitin Burkle. He is going to be the first speaker. He has done his graduation, post-graduation from Mumbai University, KEM Hospital, and the GMC JJ Group. He had obtained fellowship in pediatric as well as intra-operative echocardiography at Shened Children's Hospital, Israel. He is a fellow of the American College of Cardiology, fellow of the American Society of Echocardiography, director, Department of Cardiology of Jupiter Hospital. He has his original research papers on automated echo image analysis, and he published international biomedical engineering conferences and journals, also conducted all over India several teaching workshops on all modalities of echocardiography. He was a past president of Indian Academy of Echocardiography in the year 2014 to 2015, and is a co-author of ASE guidelines on ASD and the PFO evaluation, and AAE guidelines on the stress echocardiography in coronary artery disease, comprehensive adult transthoracic echo, and TE in cardioembolic stroke. What I would like to do is that I will invite Dr. Nitin Burkle to go ahead with the first topic, that is, how should we diagnose heart failure in 2021, a clinician's primer. Over to you, Dr. Nitin Burkle.
Thank you, Dr. Narasimhan, and thank you, Medanta Echo and Cardiology team, for inviting me. Now, this is a very pertinent topic: how to diagnose heart failure in 2021, because the clinical part remains the same, but there are certain exciting advances in the imaging. Now, this is an age-old definition of heart failure, where the heart cannot cope up with the body's metabolic need, and if at all it copes up with the stroke volume increment, but that too at a increased filling pressures. When the ejection fraction is normal, we call it as HFrEF, and when it is reduced, we call it as HFrEF. So the diagnosis of heart failure depends upon the clinical symptoms and signs of overload, then the echocardiography, the BNP biomarker, and the exercise testing. Now, none of them is. Is it okay now? Yeah.
Some technical problem?
No. Yeah. No, the entire there is nothing like a gold standard test for the diagnosis of heart failure, and it needs to be a comprehensive clinical evaluation and echocardiography, and with help of biomarkers and with exercise testing. Now, these are the age-old Framingham criteria for diagnosing heart failure. The major criteria are nocturnal dyspnea, JVP distension, RALS, cardiomegaly, and acute pulmonary edema, while the minor criteria are the bilateral edema fit, dyspnea on exertion, pleural effusion, heart rate above 120. You need at least two measure of this, or one measure with two minor, with a sensitivity of 100% with a modest specificity of 78%. Now, a very interesting study of almost 15 heart failure trials showed that dyspnea is a very sensitive symptom, but has a very modest specificity. While all the other signs and symptoms like orthopnea, LVS3, cardiomegaly, raised JVP, lung crepitations are highly specific, but they are very less sensitive. But more interestingly, this is a study done in 250 odd patients who had undergone cardiac catheterization for measurement of their left and right heart filling pressures, and blinded staff cardiologists and the trainees. And so also the BNP was corrected and the echo E by E prime and IVC was noted. Actually, interestingly, the staff cardiologists were 82% times right in diagnosing the right heart failure or increase in the right heart filling pressure. And 70% times they were correct in diagnosing the left heart filling pressure. And this was from the Gallup, RALS, JVP, lower limb edema, and ascites. The trainees did it worse, only 2/3 time in the heart failure and half the time in left heart filling pressure. But interestingly, the cardiologist as a whole could diagnose the left heart filling and the right heart filling just clinically as good as the echo, IVC, or E by E prime. So that shows that a well-trained cardiologist can actually diagnose heart failure with a great sensitivity and specificity. Now, to identify and accurately decompensated heart failure, we have different strategies about BNP and NT-proBNP. The BNP strategy is called as gray zone, where below 100, one can rule out an heart failure with a 90% sensitivity, while above 400, one can rule in the heart failure with a 91% specificity. And between 100 to 400, you have a gray zone. While for NT-proBNP, if the patient is below 50 years of age and the NT-proBNP is of 450, you have got a nice sensitivity to diagnose heart failure. But the same thing for a patient who is more than 75 years of age, you need almost 4 times higher threshold to diagnose a heart failure. Let us look at a case. This is a 43-year-old lady with a body surface area of 1.7, non-hypertensive, non-diabetic, no fever, cough, no weight loss. She had shortness of breath for last 3 to 4 days. She was admitted with orthopnea for 1 day, bilateral Krebs, saturation 80%, no edema fit. The COVID test was negative. So she had this ECG where one can see that there are RVOT, origin of ventricular premature bits. Rest of the ECG is fine, and this is her echo. Now, funnily, the echo shows that there is the septum shows only a single segment which is akinetic. Overall, there is a LV dilatation, and there are regional wall motion abnormalities. Like say here, you have got an inferior wall, you have got some a little bit of apical anterior wall. You have some certain areas like say mid septum, you have got akinesia, so and so forth. Obviously, her angiogram was normal. So she has regional wall motion abnormalities which are not conformed to a coronary artery territory. And her GLS is just -9, and you can see it is quite a variegated map showing areas which are not deforming well. And her E by E, one can look at the E by A, which was 1.8, and E deceleration time of 120, and the E velocity was 119. Now, if we look at the AAC guidelines for the LV filling pressure, then in the case when there is an LV dysfunction, if the E velocity is more than 50 and the E by A ratio is between 0.8 to 2, as in our case, then we have to look at least 2 of these points. Look at the E by E prime above 14, look at the TR velocity, and look at the LA chamber size. So let us look at our patient where the E by A ratio is between 0.8 to 2 with the E velocity is above 50. So we look at the LA volume, and the LA volume is quite high. It is 44 ml per meter square. The E by E prime is 17. So at least 2 criteria are satisfied. There is no TR, so we cannot have the TR. But definitely this patient has got a higher LV filling pressure. So this patient, looking at her left ventricular, the intriguing wall motion abnormalities, undergoes a CMR. And the CMR also shows that the septum has got a focal akinesia here. And the short axis images also show various areas of akinesia, EF of 33% and the RVF of 42%. And the enhancement shows multiple areas which are quite blotchy with a lot of late gadolinium enhancement. Like you can see here in the mid septum, you have got a lot of late gadolinium enhancement. You got certain zebra stripes here, and so forth. So it shows that there are areas where there are granulomas. Now, when you have got such a granulomatous myocarditis, the commonest thing that we have to think about is sarcoid and tuberculosis. Now, this is an HRCT which shows a lot of mediastinal lymph nodes, which do not show any, which on even on the CT doesn't show much caseation. However, this is her PET CT. Now, the PET CT is very much required in these cases to look for the focal activity in the heart, and also to look at the focal activity in the lymph nodes. And as we go ahead here, one would look at that once you enter the neck, you see a big supraclavicular lymph node with activity there. And when you enter the mediastinum, there is a lymph node with the activity. And when you go down, you have got in the myocardium, there is certain amount of activity here in the myocardium. And then below the diaphragm, you don't have any activity. So she has got mediastinal activity of lymph nodes and myocardial focal activity. And most important thing is you have got a supraclavicular node to assess. So this is the lymph node biopsy of this supraclavicular node. And always you send not only for microscopy, but also for AFP stain, TB PCR, and TB culture. So she has got TB PCR, TB culture negative, AFP stain negative, and she has got non-cacheating granulomas here. So she has got a sarcoid, cardiac sarcoid. We'll switch our gear and go to the heart failure with preserved ejection fraction. So in 2021, we diagnosed the heart failure with preserved ejection fraction with typical heart failure symptoms, EF more than 50%, wedge pressure at rest more than 15, or with exercise about 25. Now this is a cath definition. However, clinically, we have got now ESC algorithm, we have got the AAC guidelines, we have got the heart failure association PEF score, which is actually quite elaborate, and that is what we are going to discuss. And then we have got this H2 PEF score by Mayo Clinic, and then you have got the exercise cath. Let us look at the HFA PEF score, which is actually much more clinically very well to apply and quite elaborate. So we look at this particular patient. She is a 69-year-old lady with she's obese, and she's sedentary. She has got shortness of breath, non-diabetic, non-hypertensive, no COPD. She has a hypothyroidism well controlled, and her angio done previously was normal. Now this lady, one should look at the pre-test likelihood before you apply the PEP criteria. So age, she's above 60, she's obese, she's sedentary, she's non-hypertensive, non-diabetic. She probably has OSA, we don't know, she's not CKD. Now, multiple factors in this tell that she has a pre-test likelihood. And you have to exclude that there is no anemia, there is no thyroid disease, no COPD, no CKD, no valvular heart disease, no constriction, no high output state, no ischemic heart disease, and deconditioning. So the HEP score, after the test probability is high, you have to apply the PEP score, and it has got two aspects. One, in the echo, there is a morphology, which depends upon the LA volume and LV mass. And in the function domain, it is E prime, E by E prime, and TR and the GLS. While in NP domain, it is above 35 or NT-proBNP above 125. So let us look how this lady fares into this. So we look at the morphology domain. For the morphology domain, for the LA volumes and the mass, you have got different score points. So we look at her M mode, and her mass is 99 grams. Relative wall thickness is 0.42. So you don't get any score here. But let us look at the LA volume. LA volume is 40 ml, which is quite high, and we get a score of 2 here. Let us look at the function domain. The function domain gives you score depending on the E by E prime, E by E prime, and the GLS. So we look at her patient, GLS is minus 20, so we don't get any score here. Her E by E prime is 11.7, we get 1 point there. Her TR velocity is 2.18, we don't get any score here. So let us look at the natriuretic peptide domain, and her natriuretic NT-proBNP is 397. So we get 2 extra points here. So putting all this together, we have got around 5 points. So we still land up in this intermediate zone of 2 to 5. And when you are in that intermediate zone, the guidelines advise you to go for an exercise. So this exercise can be either a diastolic stress echo, where you have to show that the E prime rises above 15, then you acquire 2 scores, or the TR velocity should increase more than 3.4 meters. Or you can go for an invasive cath study, but for that you need a supine bicycle in your cath lab. And then you have to show that either the rest wedge pressure is above 15, or with exercise the LVDP goes above 16, or the wedge pressure goes with exercise the wedge pressure goes about 25. So we go with the diastolic stress echo in this patient, and you can see that there is a nice hyperdynamic LV, though increment in the MR. There is no ST depression at peak exercise. Peak VO2 is 7.7. And this is a peak TR, which is 3. So it doesn't cross 3.4. And this is a E by E prime, which is 17. So it crosses 15. So we get 2 points here. So finally, we land up with a score of 7, which is a very high probability of having an HEPPEP in her case. However, now what is the feasibility of doing a diastolic stress test? Actually, at peak exercise, you have got only 80% chance that you will get a good E by E prime, and you have got only 50% chance that you will get a good TR jet on Doppler. It needs a lot of skills there. Why not look at the peak oxygen consumption? Now, this lady has got a peak oxygen consumption which was around 7.7. Now, anything below 14 ml, there's a very high likelihood that this patient is having an HEPPEP. Anything about 20, look for non-cardiac cause of dyspnea. And again, between 40 to 20, there is a gray zone. So we are well below this 14 ml per kg. She just had 7 or 8 ml per kg per minute. But instead of doing exercise, can we look at just the LS strain? Now, this is her LS strain, and this is a reservoir strain, which was just 15. Normal is around 35 to 40%. Now, there is a data to show that as the LS strain goes on reducing, VO2 goes on reducing, and there is almost like a linear relation there. This was shown long back in 2016. So now this lady already has got a LS strain which was 15, so you expected to have a low peak VO2. Not only that, the Mayo group showed that if you have got a higher and higher PEP score, as shown on the x-axis here, the LS strain in each of these groups in a retrospective study showed a fall in the resting LS strain. So the resting LS strain, the mean and standard deviation and the interquartile range was quite low as the PEP score went on increasing. This was post-exercise PEP score. So they argue that instead of an exercise, one can also look at the LS strain when you fall in the intermediate zone before exercise on the PEP score. Can we use it more dynamically? Yes. Let us look at this lady who is 65-year-old with shortness of breath, and she is obese and non-diabetic, a TSH of 5, and her NT-proBNP is 500. And this is an echo which shows a normal LV function. LA volume is less than 34 ml per meter square, and also the E by E prime is well below 14. Now let us look at her LV and LA simultaneously, both at rest and after rest. There is a lot of information just after the leg raise. You can look at the LS strain at rest and after leg raise. And this is her LS strain at rest, and this is after the leg raise. And you have an increment of 18% to 24%. That means she can accommodate increased venous return. So her compliance is not, her LA is not non-compliant. It is compliant enough to accommodate that return. So this is a good sign. Her strain rate has also increased from the rest of 1 to 1.5 per second with just a leg raise, telling you that her left atrium looks healthy. So it is very, very unlikely that she will have an HEPPEP. And this was shown long back by the Japanese investigators that the patients with hypertensive heart disease with leg raise show increment in the volume, show delta change in the LA reservoir strain, and also delta change in the booster strain. While patients with HEPPEP either show no change in the LA volume, or they show rather no delta or a negative change in the LA reservoir strain or the booster strain. And this can also, so we make her exercise and she has a peak VO2 of 18, which is very good. So very unlikely that she has got a HEPPEP. And all peak exercise for these patients, we also look at the lung comets. So at peak exercise, there are no lung comets, again telling you that there is no pulmonary congestion with peak exercise. And this is also a very good way to look for the heart failure with exercise. And this is her rest, leg raise, and peak exercise LV and LA. And let us look at their strain. Their LA strain has progressively increased from 1824 to 30, and the strain rate has progressively increased, telling you that the LA is quite accommodative. There must not be much LA fibrosis. and this patient may be just deconditioned and is not in HEPPEP. So the thing is the behavior of the ALS strain and ALS strain rate with rest, exercise, and recovery for a normal healthy person is like this. The ALS strain goes on increasing well into the recovery, and the ALS strain rate becomes more and more negative. That means it actually increases. And at the same time, in patients with HEPPEP and HEPREP, they have an absolutely blunted change in the ALS strain and ALS strain rate. Then there is a new way of looking at the myocardium for HEPPEP, and that is looking at the myocardial fibrosis. And that you can look with the cardiac MRI by increasing the T1 values, increasing the extracellular volume, and looking at the replacement fibrosis. So there is a thought that probably looking at the myocardial characterization may be a future EF, or maybe the future target for all our neurohumoral blocking or all the trials in HEPPEP. And there is another way of looking at the HEPPEP is by finding out the phenotype clusters. And this is study by Sanjeev Shah, where you can look at that the y-axis, there are some 67 parameters, and on the x-axis, there are 397 patients. And then the computer can find out the phenotypic clusters, and from that, they have identified the BNP deficiency syndrome, the obesity cardiometabolic syndromes, and RB dysfunction cluster. So this is another way of diagnosing the HEPPEPs and then making the treatment individualized. Thank you.
I think Dr. Narsingan is not around. So thank you so much, sir, for this wonderful presentation. We'll have question answers after the second presentation. So I now invite Dr. Kasliwal to deliver his presentation on management of heart failure. What is new in this area? And then we'll have question answers. So over to you, sir.
Thank you. So firstly, thank you very much. I'm honored to be in the presence of such well-known clinical scientists who've devoted their lives to echocardiography and clinical cardiology. So my job was to talk on pharmacological management of heart failure, a field in revolution. So if you look at it, worldwide, the burden of heart failure has increased to an estimated 23 million people, and approximately 50% of cases are heart failure with reduced ejection fraction. You know, these are figures that are there every year, they keep rising. Our main point is that we should be able to pick up the patients, as Dr. Burkule has said, and then we should be able to treat them well, at least pharmacologically. So the last decade has seen substantial increase in the number of approved medical therapies for patients with heart failure. But how will you apply them till you know exactly what you are dealing with? So heart failure, it's a bigger challenge in India, and it always is, because we have a much younger population. We have low rates of health insurance, more often from a rural area. People, and also sometimes the physicians, have really little insight into what is happening to this patient. But if you look at the heart failure that heart failure is a progressive disease with deterioration of cardiac function and quality of life, then you will realize that the first time we are actually letting this person go, saying that, oh, you'll be fine, you never know when they will be back. So this is the cardiac function, hospitalization for acute decompensation, heart failure, then it becomes into a chronic decline, when ultimately there is mortality. Putting it in another word, and if you graphically depict this, you can see the course of heart failure admissions. So if the patient has come here in the early acute phase, and you have three things in your mind at that point: is the patient not improving? Is the patient worsening? Is the process stalled? Or is there improvement towards the target? If you're in the pink zone, then the patient is doing well. Then he goes into an optimization phase, early post-discharge phase, and the transition to chronic heart failure. This is what we feel should happen all the time, but it doesn't. Many a times it doesn't happen that way. And you will see that improving towards target, I will come later, but initial improvement and then stalled, you will have to look at higher doses of diuretics. First thing in pharmacology, which we must understand. Other strategies such as IV vasodilators. Consider invasive hemodynamic assessment, and that can help sometimes, and review any recent medications. And if this still not improving or there is consideration, then you will look at hemodynamic monitoring, consider IV inotropes and other things. So very importantly, when the patient is admitted with you, you will have to see that the patient goes along a trajectory, is not stalled, and if there is stallment, then what should you be doing? And those pharmacological therapies are well known, but to put them into correct perspective is the difficult thing. So our object is first to clinically diagnose, to be able to clinically diagnose heart failure, whether with reduced ejection fraction, that's what I'm talking about, and look at the signs of morbidity. We have to relieve symptoms and signs. We have to improve quality of life, eliminate, but certainly reduce fatigue and breathlessness, reduce requirement for hospitalization, and provide end of life care if it comes like this. It comes so. But to me, one of the most important things are which have a financially draining and which are mentally draining as well is the recurrent hospitalization with patients of reduced ejection fraction have to face. If we take the pharmacotherapy seriously and if we apply our things correctly, then we will be able to prevent the occurrence of myocardial damage, very important. We will be able to stop the progression of myocardial damage, remodeling of myocardium, and recurrence of symptoms. See, if you look at it, these are the four most important things. Can we remodel? Can we stop the recurrence of symptoms and fluid accumulation? Can we stop the progression of myocardial damage? If we could do this, this patient will go home and will visit us only in the outpatients department. So drugs for management of heart failure with reduced ejection fraction, as you can see, you can start with diuretics, ARBs, and I'll come to those, beta blockers. Sometimes you have to use ivabradine, MRA, very, very important, and metolazone hydrochloride. But just look at it. Somewhere down the line, even vaccinations are important. These are important to, like the flu vaccines and this pneumococcal disease. These also have to be looked into when we are dealing with the core therapy plus other drugs for the management of heart failure with reduced ejection fraction. Now, it just happened that I was in the United Kingdom in 1987 when the consensus study using anurap in patients with heart failure. And I was really impressed by the way such trials are conducted, A, and B, how from the era of digoxin and diuretics, we actually entered into an era of ACE inhibitors, later on ARBs, then came ERNI, and then came the SGLT2 inhibitors. So this has been a huge evolution, and for our understanding, we must know something about most of these things. And as you can see, 2001 rematch, companion study, then came the agents like CRTD, dysynchrony, and so on. But if I look at the whole spectrum, and as I've been seeing it from 1987 through 2014, really the thing that made the huge difference was the paradigm HF. And the word was selected very well. It was really a holistic paradigm change and give a good outlook to the patients of heart failure. So evolving foundational therapy for heart failure, we have seen ACE, beta blockers, MRAs, ivabradine, ERNI, and SGLT2I inhibitors. And the first thing that came to our mind with sacubitril valsartan combination was that the sac-val combination not only blocks the renin-angiotensin system, which it does, but also enhances the activity of vasoactive substances such as peptides and bradykinin. This is what made these two agents very unique. If you read the Frame of Mind article by Dr. J.J. by Dr. McMurray, he was very clear that this was the association between the finest in the drug like this and the potential mechanisms of benefit were that it increased vasodilatation, decreased sympathetic nervous system, increased parasympathetic nervous system activity, and importantly, caused natriuresis and diuresis and favorable cardiac remodeling. All these things are important. All these things are important in the long term, because otherwise, once you have diagnosed heart failure, then you will say, okay, within a specified period of time, this person may not be there. Cardiac fibrosis, hypertrophy, and the risk of arrhythmias, all these things are actually decreased when you're dealing with SAC-valve combination. And you can see here very well with angiotensin receptor blockers, you decrease mortality by 15%, and by added ACE if you add ACE inhibitors by 18%. But if you had actually got the SAC-valve combination that we use now, you decreased it substantially. And that's what has been the real paradigm change in our management of heart failure. So 2014 paradigm HF, then titration studies in Pioneer and I will just briefly touch on two studies which have made a big difference and in our lives for our patients. So paradigm HF was the largest clinical trial on heart failure. It was a double-blinded randomized study, 7,980 patients, and enalapril 10 milligrams twice daily was put against LCZ 200 milligrams twice daily. And straight, there was if you looked at the CV death or heart failure hospitalization, the primary endpoint, you could see that with ERNI, you could decrease it substantially. And that's what the point is. Look at the p-value of this condition. That we had hit upon something which actually took us conventional therapy. And if you look at 30-day heart failure hospitalization, there was a 40% reduction in first hospitalization. And mind you, I'm repeating, this is one thing which has made a big difference into my thinking as a cardiologist for my patients, because they're coming back again and again breaks them physically and of course financially. The between group differences in the risk of hospitalization for heart failure was statistically significant as early as 30 days following randomization. And this is the classic work of Dr. Milton Packer and his group, and they have done really remarkable work. So, and the other key endpoints were, there was a decrease in cardiovascular death, 20%, heart failure hospitalization, 20%, overall mortality, heart failure deaths, and sudden deaths. Now, this has been a constant feature with our, there are many symposia being held on heart failure with reduced ejection fraction, and we know all these things. The question is, are we applying this for our patients? That is the important thing. That whatever way we start, whether we start 50 milligrams twice daily, this study of course had 20 milligram, 200 milligram, but we should be able to give it. So ERNI should not be concomitant. The only word of caution here, should not be administered concomitantly with ACE inhibitors or within 36 hours within last dose of ACI dose. So, and ERNI should not be administered to patients with a history of angioedema. So all these things are in your hands. I mean, you can assess them and then go from there. I just allude to Pioneer HF, patients with acute decompensated heart failure. Now, many times we feel, okay, we are discharging the patient. When he comes back, we'll do it. But no, if the patient is stabilized while still in the hospital, systolic blood pressure is over 100 millimeters of mercury, there's no increase in IV diuretics for 6 hours, then to start start ERNI in the hospital itself, because he's under your care. You can see the creatinine levels, you can see the potassium levels, and you can with great confidence now tell the patient that yes, he can be discharged. And that also gives him the confidence that there's nothing new that's going to happen. They are giving me the same medicine that they have done it. And if you look at the Pioneer HF early clinical benefit, as you can see very clearly how sacubitril valsartan in red showed a decrease in the CV death or hospitalization for heart failure. But see, importantly, it also showed a difference, a change in the NT-proBNP levels. Now, Dr. Burkule has emphasized on the NT-proBNP, not only for diagnosis, but also for continuum. It's very important that this should be one parameter which we can say, yes, it came down, patient was stable in the hospital, so we discharged him, and we are calling him in the hospital only so that if the blood pressure increases, we may like to increase the dosage. So pioneer heart failure outcomes in patients without prior ACE and ARBs exposure, and you can see the change in NT-proBNP level was very good, and the CV deaths or hospitalizations were again for hospitalization were very good. As I said, it's huge, the difference between CV death or hospitalization for heart failure, and these are acute patients. So you already started making a difference in their life. Fact that, look, my life is not coming to an end. That's a very big thing. And if you look at the pre-specified subgroup analysis, you will see that there is an overall betterment in most of the parameters. Look at the breakdown of patient enrollment, de novo patients, worsening chronic heart failure, worsening chronic heart, all these parameters all these groups are there. And those who are hospitalized under your care, you may as well start early. Reverse cardiac remodeling also. Now, this is something which echocardiography has made a big difference in. It's not just about ejection fraction. Of course it is, in the sense that ejection fraction improves. But most important, if there is favorable remodeling, if there is reversal of cardiac remodeling, this patient already has told you that he's going to live longer and better. 25% of subjects experience an LVEF increase in more than 13% at 12 months. And so this is an important thing. So shifting gears at this time and coming to the other big chunk of patients who are now being treated with patients with heart failure have similar pathophysiological features as patients with diabetes. And people realize that they are shared. Just shifting gears here, heart failure in blue, diabetes in red, as you can see, endothelial dysfunction, insulin resistance, mitochondrial dysfunction, RAS, all these are very common in both these conditions. So many of these conditions who are obese, metabolic, and have insulin resistance, these are patients who may be on other medications like the sodium glucose co-transporter 2, SGLT2 inhibitors. And we know that these prevent the development of heart failure in patients with type 2 diabetes. We know that. And these have been huge studies. Can they be used to treat patients with established heart failure? The answer is, of course, yes, but we'll come to that. And the benefits dependent. So can SGLT2 inhibitors be used to treat patients without? So both are important questions. And if you look at SGLT2 inhibitors, how do they work? They cause diuresis, natriuresis, glycosuria, but they decrease proteinuria. That is important. And the rationale for exploring SGLT2 inhibitors for the treatment of heart failure in patients without diabetes became clear, because there is a mechanistic rationale to investigate the CV outcomes in SGLT2 inhibitors beyond diabetes, and this has been found to be important. The CV benefits observed were largely independent of the glucose levels. So the two drugs that I'm going to talk about have actually been shown to have cardiovascular outcomes were largely independent of the glucose. So now you have another set of medications, and there have been a huge work done on this in this condition. The evolution of heart failure management from a normal ventricular function to end-stage heart disease, preclinical, clinical, and detectable cardiac involvement. In all these various, if you can divide them into three parts, then you can actually use dapagliflozin and you can use empagliflozin with, and these may be non-diabetic patients as well. That's the important thing. But if you look at DAPA, for example, if you look at primary outcomes, the outcomes with DAPA-HF dapagliflozin are much better. If you look at hospitalization for heart failure, far less patients came back again. Death from cardiovascular disease and death from any cause. So these patients who have insulin resistance and are obese and those whose blood pressures are take advantage of starting with dapagliflozin. And overview of results from DAPA-HF studies have shown that the worsening heart failure or CV deaths is decreased, heart failure or CV deaths decreases, total heart failure, CV death events. So all these things you can see, the rates of AIs were similar between DAPA and placebo. Look at this statement, this is huge. The rate of adverse events was similar between DAPA and placebo. So as you can see that whether your patient had diabetes mellitus at baseline or didn't, so that means those patients who we share with our diabetes colleagues should definitely be on these drugs. And so this was the first drug that was introduced, and then of course came in empagliflozin, and the Emperor Reduced study showed the same thing, that you had decrease in rate of death or hospitalization again, and Emperor Reduced effect on individual components of the primary endpoint again were huge. So, and the numbers are quite robust. If you look at one of the studies, the Emperor Reduced, numbers 1863 and in placebo 1867, pretty well, and patient years, 100 patient years per year, and so very well managed. And if you look at the primary composite endpoints, the p-value is 0.001, so which tells you that you have things in your hands where you can change the patient's life. Emperor Reduced, slope of decline in glomerular filtration rate, these also have a good effect on the glomerular filtration rate. And I tell you, sometimes we as cardiologists, we get stuck because patients' GFR goes down. And so these are the drugs which we can use to really enhance their, and then of course the Victoria trial, this is on Verisubart, global study in subjects with heart failure with reduced ejection fraction. And this also tells us that this is a useful agent. So guidelines continue to evolve with increasing evidences in heart failure with reduced ejection fraction. And even if you look at what I've marked in red, initiation of a SEC-well combination, the SV, rather than an ACE or an ARB, may be considered for patients hospitalized with new onset heart failure or decompensated heart failure to reduce the short-term risk of adverse events. And so simplify management by avoiding the need to titrate ACE first and then switch to SEC-well. Because these patients are already at high, I mean, they can be nothing more higher risk than patients who had the first episode of heart failure. There is no need to check plasma concentrations of natriuretic peptides, but of course, on a follow-up, you would like to do that. So if you look at the treatment algorithm, clinicians should aim to achieve optimal goal-directed medical therapy within 3 months or 6 months of an initial diagnosis of heart failure with reduced ejection fraction. ARNI may be your preferred choice as foundation therapy along with beta blockers and diuretics, and you can use both these agents together actually. There is no problem about that. And apart from pharmacological therapy, as you can see, there are cardiac resynchronization therapy has made a huge impact. So you can put them on good pharmacological therapy, and then also, if so required, if their QRS is widened, you can actually, and dysynchrony is there, you can put them on CRTD devices. And of course, sometimes patients after decongestion, when they're found to have mitral regurgitation, in New England Journal of Medicine, which doesn't say so much, but mitral clips and a coapt, these can be things that we can use. So novel considerations in optimizing care for her patients with heart failure, gaps between the guidelines and the real life, that's important. Lack of awareness, lack of access to anti-proBNP testing, need a better screening of heart failure. Dr. Burkle has very nicely defined. Even if you don't go into huge details of MRI, or at least echocardiography should be used to the maximum. And you can use it for heart failure screening programs. Better education of heart failure is required for not only patients, but clinicians and also their relatives. Under optimization of drug regimens and under adherence of guidelines, these are very, very important. Sometimes financially, you may come across these issues. And access to heart failure centers and cardiac rehabilitation programs. All these are very important for the patients to actually adhere to your medication and take it forward. So Dr. Bansal, Dr. Burkale, and Dr. Narsingan, I would end by saying that heart failure is a major public health concern with substantial morbidity, and I would say substantial morbidity and mortality. Disease morbidity and mortality remain high, with a 5-year survival rate of 25% after hospitalization for heart failure with reduced ejection fraction. The management has seen significant scientific breakthrough. There is no doubt about it. This is one field in which we have grown from, and there was a very nice article, is deduction the effect, is the effect withering, something like that, somebody had written. So the management of heart failure with reduced ejection fraction has seen significant scientific breakthroughs in recent decades, and the ability to alter the natural history of disease has never been better. Real developments include ARNI, SGLT2 inhibitors, Vericiguat, transcatheter mitral valve repairs, and devices. All of these have incrementally improved the prognosis in patients with heart failure with reduced ejection fraction. Thank you very much, sir. Thank you, ladies and gentlemen.
I think we had listened to two eminent cardiologists talk on two different subjects on heart failure, and we were probably thrilled to know that so much of advances had taken place in the field of echocardiography, particularly to make the diagnosis almost equivalent to that of the clinical diagnosis what the clinicians are making. That is the first slide which attracted my attention from Dr. Buckley. At the same time, he also went on to describe about the LA strain, which probably will pave the way for us to understand better with respect to the risk at which the LA strain is detected. And when the legs are raised, what's happening to the LA strain? He has identified in one case and he had given the readings also. And it clearly indicates that how useful it is to identify the PEF in patients with the problems of heart failure. He also went on to talk about the phenotype heat map as well as the LA strain map, and he also insisted on the usefulness of this particular modality. People who are obese, people who are having cardiometabolic features, and those people with elevated BNP correlating the data. And we are really thankful to you, sir, for updating our knowledge in this field, particularly in echocardiography. At the same time, I would like to probably again appreciate Dr. Ravi Kesliwal for his overview of the pharmacological therapy in the management of heart failure. And of course, we need to diagnose heart failure properly. One on clinical diagnosis, two on the biochemical, particularly the BNP, third in echocardiography. After making the proper diagnosis, our aim is to probably prevent the problem of sudden cardiac death which can occur even in the first admission. Our aim is to be very, very aggressive in treating these patients. Once when they go for a chronic stage heart failure, there is an indication for so many drugs which are available now. He went on to talk about not only the usual drugs like ACE inhibitors or ARB or the beta blockers, and the newer introduction of these drugs which are probably playing a major role. The aldosterone antagonists have shown as the better way of managing people with heart failure. But now the combination of sacubitril and valsartan, which is coming under the name of Harney, is a better molecule when compared to simply starting the patients on ACE inhibitor, because he has shown a lot of evidence to talk about the efficacy of this particular molecule in comparison to the enalapril, which was done in this paradigm study, which has shown 20% reduction in the cardiovascular death, 20% reduction in hospitalization for heart failure. That is something which is very, very useful, valid information, which is started projecting, so that we can probably straight away start these patients on sacubitril valsartan combination instead of choosing ACE inhibitors and updating the dose, or instead of choosing an ARB and going for that. You would have seen in one slide projection where he had made
how useful it is for to understand the mortality benefit for ACE inhibitor, mortality benefit for ARB, and the mortality benefit which is seen with the sacubitril combination. Excellent coverage of that particular information, sir. And I am also very happy that you touched upon the diabetic persons with the problem of heart failure, where you had indicated that the role for SGLT2 inhibitors, originally described as a diabetes drug. Now we know that it has got multiple actions, including pleiotropic effects, and it is now being preferred as a cardiac drug. We know very well that it is useful not only in people with established heart failure, but also in people in whom there is no diabetes. In those people also, probably this may be a good drug, as yet projected in Pioneer study and other studies. I think the time is not far off to switch over to this sort of SGLT2 inhibitors therapy in the therapeutic armamentarium for patients with heart failure. So, ladies and gentlemen who are watching this particular program, I need to tell you that in-hospital mortality in our country is about 9.7%. If you start treating patients aggressively, probably you can reduce the burden, reduce the sudden cardiac death also. Don't give a guideline-directed medical therapy, probably suboptimal management will be done for these patients. And at the end of 3 months, you will have triple the rate of mortality. At the end of 1 year, we'll have double the rate of mortality, which is again being witnessed by all of us. I think we should change our approach in managing heart failure, not only in the diagnosis, but also implementing in the newer therapeutic choices, which are going to be really useful for producing much longevity, minimizing the complication, minimizing the repeated hospitalization for heart failure, and preventing the sudden complications, including sudden cardiac death. Of course, he had also given us information about the devices which will help these patients when they are still symptomatic and they're going in for so-called resistant failure. At that stage, probably we need to submit this patient. This is a small summary. I think I should probably be in a position to take some questions from the chat box. Also, there are some questions. I'm sure the eminent cardiologists, including Dr. Manish, will be able to throw some light on these issues. Can I just start giving you the questions, sir? Is it okay, sir?
Yes, sir. Yes, sir. Please, sir.
Any SGLT2 inhibitor or especially DAPA should be the use for CV benefit outcome. Would you like to answer, sir? Dr. Ravi Kasliwal?
Sorry, I didn't get the question.
Any SGLT2 inhibitor or especially dapagliflozin can be of use for cardiovascular system benefit outcome.
No, true. So I've mentioned two of these, and you can use either of them. There's a class effect, no doubt about it, amongst the SGLT2I. And they're very useful drugs, truly. In those who are metabolic, insulin resistant, and they may not even be diabetics, non-diabetics, and the pressures are borderline. These are the patients. So what I've tried to project is that today, in the 21st century, the clinician cannot say that there were not enough data in my hands. There is enough data. There is enough therapy. And you very rightly said that this is the in-hospital, and after 1 year, this is the mortality after 1 year. That mortality should decrease. Why? Because we have now drugs which were supposed to be good for diabetic patients. They can be used in non-diabetic patients as well. Of course, they can be very useful in diabetic patients. They decrease the, as I said, the thing that strikes me most is the recurrent rate of hospitalization. That is mentally and physically that breaks the patient, and financially. Period, nothing like it. So we can use the SGLT2 inhibitors, undoubtedly.
Yeah, there is one more question in the chat box. Sir, will you recommend to start ARNI in patients who develop heart failure / cardiomyopathy during hospitalization or post-discharge? The COVID-19 infection, these patients did not have any kind of comorbidities prior to COVID-19 infection.
No, this question has two components. The first thing, the component is that will I start ARNI in the hospital for acute decompensated heart failure? The answer is capital yes, I will do that. And that's why I briefly refer to the Pioneer study, in which when the pressures come up, When the use of inotropes go down, vasodilators have been stopped, it is much better to start a new therapy in front of you. So you can not only tell the patient, but you can also feel comfortable that yes, the patient is accepting it without any great fall of pressure. So definitely.
Yes, you raised one more question. Any role for RNA in preserved ejection fraction? Heart failure.
Yes, the US FDA has cleared the use of, and Dr. Burkole can also answer that question, but they have cleared this earning for the use in heart failure with preserved ejection fraction. Anyway, even before the US FDA did it, we were using this combination in patients of with who had hypertension or mildly elevated pressures. We were using this combination because it has definitely got a good effect on decreasing the LVEDP.
I would like to have your comments, sir, Dr. Gokli, please.
Yeah, truly. As the Dr. Kasliwal has pointed out, that we are actually using it before even the approval for the simple reason because even in the trial, the median EF, which was 56%, patients below 56% also showed benefit with ARNI. So I think many of our HFpEF patients are in that range of 50 to 55%. So I think it is very safe to do that. Plus, women with much higher ejection fraction also should benefit with the ARNIs. So I think for the women, we can extend the EF to 60% too. So I think there is no. I think probably the trial fell short by a very small margin in reaching the p-value. But otherwise, I think there is a large chunk of patient in the HFpEF group which will be benefited with ARNIs.
I would like to get a comment from your side. Most of the patients who are obese with the features of metabolic syndrome, plus or minus diabetes, the report from the echocardiographer or from the cardiologist is that there is a diastolic dysfunction. How do you approach these patients when they are totally symptom free and they don't have other than the metabolic problems or mild hypertension? How do you probably prognosticate it? Do you think that they are at the edge of developing heart failure at a later stage?
I think the patients with the diastolic dysfunction, when they cross over to clinical heart failure, is actually a big mystery. However, I think the first diagnosis of say grade 2 or more diastolic dysfunction itself should ring the alarm bell that these patients are developing myocardial fibrosis and so also the left atrial dysfunction. I think this patient should go on definitely should have the neurohumoral blocking drugs and a stringent lifestyle modification and correction of obesity, obstructive sleep apnea, so on and so forth. Now it's only a matter of time that they will cross over to clinical heart failure. Now, heart failure is finally a clinical diagnosis and also justified by a rise in the natriuretic peptides. Now, when this crossover from advanced diastolic dysfunction to clinical heart failure occurs, is very difficult to catch. There may be some role of ALA dysfunction which may be instrumental in this crossover. But I think all these patients with the risk factors and having the echocardiography report showing at least grade 2 diastolic dysfunction, I think we should start on a very neurohumoral blocking drugs and also a very strict lifestyle modification.
I think, can I disturb Dr. Manish Bansal for one question? Is it okay, Dr. Manish?
Yes, sir. Yes, sir.
Yeah.
Sir,
No. At the stage when you see patients who are actually stabilized in the ICU with the increasing dose of diuretic, patient is comfortable. Would you like to start the patient on RNA or SGLT2 inhibitor? Of course, the patient is a diabetic. Tell me, if the patient is a diabetic, the patient is not a diabetic. What will you do?
So in both cases, I think the ultimate goal will be that the patient should be on both the drugs.
Okay.
But when the patient has just recovered from acute decompensated heart failure and is still in the hospital, because of the hemodynamics, I'm sure we will not be able to start both the drugs before discharge. At the most, we'll be able to start just one of these two drugs. So what I will do is that if the patient appears to be if blood pressure allows and there's not much congestion, my preference would be ARNI first, because in any case we have to start with ACE inhibitor or ARNI, one of these two drugs for heart failure. HFrEF I'm talking about. I would prefer to go for ARNI because of the evidence that we have, because that is the only trial where the drug was compared with an active drug, which has been the gold standard in treatment of heart failure, paradigm heart failure. So because of that evidence, I will go for ARNI first. However, if the patient's blood pressure is borderline and patient appears to be congested also, in that situation, my preference may be for SGLT2 inhibitor because it will cause some diuresis also, and it may not reduce blood pressure to that much extent. But it's going to be a difficult choice, sir.
Yeah, it was a very good answer that you have given substantial evidence to say that somehow no, you have to start the patient on an ACE inhibitor for the treatment of heart failure. Instead of starting ACE inhibitor, why not to straight away go for an ARNI? In certain
Yes, sir.
situations, probably once everything is stabilized, probably you can add in SGLT2 inhibitors. So the combination
sir.
of drugs probably can be encouraged in certain situations where you would like to probably aggressively treat these patients and bring them to a normalcy
Yes, sir.
state. Sir, what are your current practice as far as aldosterone antagonist is concerned? Do you still prefer spironolactone based on trial study? Or would you like to probably put the patient on eplerenone based on FEC study? Which one will be the ideal one in your clinical practice that you are probably planning to start already starting?
So I've been using eplerenone more often because of the better side effect profile. But contrary to what guidelines recommend, I have faced a major problem because of hyperkalemia when the patient is on both an aldosterone antagonist and ACE inhibitor or even ARNI. So that has been a challenge, but my preference has been for eplerenone more often than electron.
So all the three can probably give me the proper answer as far as I am concerned. Is the problem is from my side only. When you choose a beta blocker, do you think that carvedilol will be the better choice when compared to the existing beta blocker in therapy for heart failure? If so, why?
For beta blocker, again, sir, actually for beta blocker, I've been using more often metoprolol succinate or bisoprolol. All the three drugs have shown good data. I don't think there's anything to choose one over other, although there are some differences in their pharmacodynamic properties with some vasodilation with carvedilol, which is supposed to minimize the risk of causing decompensation when beta blocker is added to a patient with heart failure. But my preference has been bisoprolol and metoprolol succinate.
Okay, instead of carvedilol.
Yes, sir. It's more of because of familiarity and comfort level.
Dr. Berkeley, your comment, please.
Yeah, my choice had always been bisoprolol because that it has got very small denominations available right from 1.25, so titration becomes very easy. Metoprolol, the challenge many times is when they are taking sustained release preparation, it is very difficult to up titrate the dose. And in beta blockers, I think come what may, one has to reach the guideline directed maximal dose. So this up titration, very gradual up titration becomes very easy with bisoprolol. It is also easy with carvedilol, but somehow with clinical experience, I find that the heart rate control is very good with bisoprolol as compared to carvedilol. So that is why I generally prefer that. Or many times earlier when we are up very small doses of beta blockers just to bring down the heart rate, I may transiently add an ivabradine, and then as the beta blocker builds up, I may take it away once I reach the target heart rate, the target beta blocker dose.
Okay, if you have started these patients on the continuous drugs of usual conventional therapy, and in case the heart rate is higher, you are probably going to start the patient on an ivabradine. Do you think that we should continuously give ivabradine along with all these drugs, or stop it at the stage when the patient reaches the heart rate less than 65 or 64? Stop it.
I think one has to give a walkover to beta blockers because of their so many other pleiotropic benefits, right from preventing apoptosis to preventing arrhythmias and sudden cardiac deaths. So I think heart rate cannot be the only target. So I think one should give a walkover to beta blockers, and if the beta blockers at their higher dosages are bringing down the resting heart rate in the range of 60 to 70, then I think we can straight away give up on the ivabradine and did not have to stick to it. Another issue, a little troubling issue about the ivabradine is about the increase in the incidence of atrial fibrillations. It's very common in the ICU settings where ivabradine is started left, right, center by the intensivist, and patient lands up with the atrial fibrillation.
I think the next question probably will be on hydrazine and isosorbate dinitrate combination. Will you be in a position to throw some light on this particular combination in patients with a heart failure? When will you choose this?
Actually, my choice, though in the West they are using it for the African American population, but in our setting, I think the first and the commonest indication for us is the patients with a chronic kidney disease and heart failure. Because most of these patients do not tolerate ACE inhibitors, ARBs or ARNIs when their GFR is well below 50. So I think, and they are always significantly hypertensive. So they are reaching that dose of the maximum dose of isosorbate dinitrate with hydrolyzine is very easy to achieve. So that is my first preference. Second is obviously patients who are already now before ARNI. On ARNI the blood pressure control is extraordinarily well. Rather you go more towards hypotension. But earlier there used to be heart failure patients where you reach the guideline directed maximal dose of ACE inhibitors, like say 10 milligram of ramipril. Or 10 milligram or 20 milligram of enalapril, and still the blood pressure is higher. We used to add the hydrolyzine and mononitrate combination. But I think now with the advent of ARNI, it rarely is a consideration.
I don't think any other question is there in the chat box. Let me just verify it before we conclude, sir. Can you permit me to do that?
Yes, sir. Yes, sir. Please, sir.
I think we have completed the questions from the chat box. I think Dr. Ravi Kasliwal is not to be seen there anyway. Shall we wind up the session?
Yes, sir. Yes, sir. Please, sir.
I think we had an excellent coverage of the topic, which are very, very important in the field of cardiology in general and heart failure in particular. Not only for the diagnosis, but also for the management of these patients to reduce the morbidity and the mortality. And I think every cardiologist should try to prevent heart failure in those people who are at a risk of developing it. At the stage when he is not developing any problem, you have to prevent it. Of course, you need to probably prevent repeated hospitalization for heart failure. Once the fellow comes out of ICU, you need to take all precautions to prevent the heart failure readmissions and prolong his life with the available modern useful drugs in 21st. That's my concluding. Thank you very much, sir. Thank you. Would you like to add something, sir?
Very much, sir.
So nice, sir. Thank you.
Thank you, sir.
Thank you. Thank you very much, sir. Thank you.
Thank you so much, sir, for chairing the session. Thank you to Dr. Burkule and Dr. Kasliwal for the excellent presentations, and all the participants who joined for this webinar and asked their questions, which allowed us to have a very good discussion on this very important topic. So thank you once again, everyone, and we'll meet again after 1 month for another very clinically relevant topic. Thank you.
So nice. Thank you.